Very good evening, guys. Welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. So, in this session, we are going to discuss again a wonderful set of MCQs for your practice. So, I hope you're all aware that May 21st is your exam, and right. So, I want you to prepare, put your soul into it, and go on doing MCQs and prepare well. Just concentrate on Dr. Bhatia Medical Coaching. So concentrate on something which you are weak or where you tend to forget a lot, or the mistakes which you have done. So try to revise that. And even if you read the last 15 days with positiveness and with a lot of, put your, matlab, there's nothing else apart from this. 100% concentration. Still you can get a very good rank, good seat, everything whatever you dream of, right? So just be positive and keep preparing, right? So let us last session you told me to keep some topics, so I have kept those topics. That is, you have asked me to do GTN, you have asked me to do Partogram, NST. So I have kept those topics MCQs also only in this session, so that you will have a practice of those topics. Okay, so 36-year-old, Gravida 2, Para 1, Para 0, Gravida 1 woman presents for her first prenatal visit late in her first trimester of pregnancy. She complains of persistent vaginal bleeding, nausea, and pelvic pain. Physical examination is notable for a gravid uterus larger than the expected for gestational age. Fetal tones are absent. Which of the following is most likely to be true? So what is this USG telling us? What is this appearance called as, and what is the diagnosis for this ultrasound? So beta HCG levels will be higher than normal, beta HCG levels will be lower than normal, uterus will be lower than normal levels, TSH levels will be increased. So what is this ultrasound telling us, and what is the diagnosis here first? Right. So this is nothing but the snowstorm appearance, and this is very classical of molar pregnancy. So this is snowstorm appearance, and this is very classical of molar pregnancy. Yes, and to be precise, this is complete mole. This is complete mole. So in complete mole, uterus will be larger than the gestational age, and uterus will be soft and doughy. Right? So this is wrong. And beta HCG levels will be higher than the normal is a correct statement. What will happen to the TSH levels in the molar pregnancy? So as alpha subunit of HCG is similar to FSH, LH and TSH. So this alpha subunit will stimulate the thyroid gland to produce T3 and T4. So that is why there is risk of thyrotoxicosis. So this T3, T4 causes negative feedback on TSH. So TSH levels will be less. Yes. So TSH levels will be less, whereas T3 and T4 levels will be high, right? And this is called as yes, usually this is diploid, and the molar pregnancy entire baby is only of paternal in origin. So the entire baby is of paternal in origin. So this complete mole has the risk of progressing into gestational trophoblastic neoplasia. So this is gestational trophoblastic disease which has a potential to transform into malignant. So under gestational trophoblastic neoplasia, we mainly have four things. Yes, Nasira. So beta HCG is specific, whereas alpha subunit is similar to FSH, LH and TSH. So under GTN we have invasive mole or chorioadenoma destruens, invasive mole, choriocarcinoma, invasive mole, choriocarcinoma. Next, placental site trophoblastic tumor, and epithelioid trophoblastic tumor, right? So these are the 4 malignant GTN, gestational trophoblastic neoplasia, invasive mole or chorioadenoma destruens, choriocarcinoma, placental site trophoblastic tumor, and epithelioid trophoblastic tumor. So now if we go back, the criteria for GTN are all except. Persistently increasing beta HCG for 3 weeks, plateau levels of HCG for 4 weeks, theca luteins of 6 centimeters, histological criteria for choriocarcinoma. So let us see what is the criteria for GTN and we will come back to this question. So the criteria for gestational trophoblastic neoplasia is plateau of serum beta HCG level plus or minus 10% for 4 measurements during a period of 3 weeks or longer. So plateau should be 4 measurements, guys. So in a period of 3 weeks, over a period of 3 weeks, that is 4 measurements. Rise of serum beta HCG more than 10% during 3 weekly consecutive measurements or longer during a period of 2 weeks or more. So day 1, 7 and 14 should be a rise of more than 10%. Plateau is 10%. Serum beta HCG levels remain detectable for 6 months or more. And histological criteria for choriocarcinoma. So these are the criteria to call it as gestational trophoblastic neoplasia. So persistently increasing beta HCG for 3 weeks. Yes. So 3 weeks persistently rising beta HCG is a criteria. Plateau for 4 weeks is also a criteria. Histological criteria for choriocarcinoma is also there. But theca lutein cyst of 6 centimeters is not a criteria. Theca lutein cyst for 6 centimeters is not a criteria for GTN, but it is a high risk that they can go into GTN. Next, very important question. 41-year-old woman complains of irregular bleeding for 7 months after delivery of her 4th baby. 41. Curettage is performed and histology reveals a choriocarcinoma. Her serum beta HCG level is 2 lakh. Lungs are showing the following appearance. So what is this appearance the lungs are showing here? So this is called cannonball appearance. Which is very classical of choriocarcinoma, right? What is the most appropriate next step in the management? Commence treatment with intramuscular methotrexate, commence treatment with multi-agent combination chemotherapy, perform a hysterectomy, repeat serum HCG after 4 weeks. So to solve this, so this is very clear that you are seeing cannonball appearance. So these cannonball appearance are mainly seen in choriocarcinoma. Cannonball mets are seen in choriocarcinoma. Can you tell me in which stage do you see cannonball mets? So in which stage do you see cannonball mets? So indirectly I'm asking you, lung involvement belongs to which stage? So stage 1, yes, excellent. So it belongs to stage 3. So stage 1 is confined to the uterus. Stage 2 to the adjacent structures, that is adnexa, vagina, broad ligament. Lungs, stage 3. This was asked as an MCQ. Lungs belongs to which stage? Stage 3. Stage 4, the lesions metastasize to brain, liver or GI tract. Now, you should know the WHO scoring system, guys. You should know WHO scoring system. Now, this is little difficult, but yes, ho sake to try to memorize, So, on the whole, if you remember, the patient's age was 41. So, 41 means score of 1 she'll get. My advice is remember what is zero score. So, age less than 40 years is zero score. Antecedent pregnancy agar hydatid for mole, so it is a zero score. So if you remember, this patient had 4th delivery and term baby was delivered, so she gets a score of 2. So whenever a molar pregnancy comes after a term pregnancy, it gets a score of 2. So you get another score of 2. Interval months from the index pregnancy. If less than 4, 0, 4 to 7, 1, 7 to 13, again a score of 2. So this lady was having irregular bleeding 7 months after delivery. So again a score of 2. Right? Pre-treatment HCG less than 1000, 0, less than 10,000, 1, less than 1 lakh, 2, more than 1 lakh, 4. This patient had more than 2 lakhs. So 4. So her score will go for 4. So whenever you have score of more than 7, more than or equal to 7, you call it as high risk. And if you have less than or equal to 7, less than 7 or 6, less than 7 is 6, so I'm writing 6, then it will be called as low risk. So this is going for 8 already. Tumor size was not mentioned to us. So less than 3, 0, 3 to 5, 1, more than 5, 2. Lung mets 0, spleen and kidney 1, GI tract 2, liver and brain 4. Number of mets, if it is 1 to 4, you get a score of 1. 5 to 8, you get a score of 2. More than 8, you get a score of 4. Previous failed chemotherapy, 1 drug, you get a score of 2. More than 2 drugs, you get a score of 4. So this WHO scoring system is something which is important, guys. So when all we get 0 score, if age of the patient is less than 40 years, if antecedent pregnancy is hydatid for mole, if interval months from the index pregnancy is less than 4, or if pre-treatment HCG is less than 1000, large tumor size less than 3 centimeters, or the site of mets is lung, then you have a score of 0. Interval month from the index pregnancy more than 13, pre-treatment HCG more than 1 lakh, if site of mets are liver and brain, or if number of mets are more than 8, or previous failed chemotherapy more than 2 drugs, you get a score of 4. You get a score of 4. So this is a high risk. High risk. Stage 3, high risk. This patient is stage 3, high risk. Right? So now I'll tell you one table to remember. So stage 1, low risk, you can give single agent chemotherapy. So basically for low risk it is single agent chemo. For high risk it is combination chemo. This is what you have to remember. And how do you decide whether she is high risk or low risk? It is based on the WHO scoring system. It is based on the WHO scoring system. Right? So stage 1 FIGO with low risk WHO, it is single agent chemo. Stage 1 FIGO with high risk WHO, you are going to give combination chemotherapy plus hysterectomy. Stage 2 or 3 FIGO with low risk WHO, it is single agent chemo plus hysterectomy. Plus or minus depending on whether family is complete or not. Stage 2 and 3 high risk combination chemo, hysterectomy plus hysterectomy. Stage 4 combination chemotherapy plus hysterectomy because brain and liver is involved, metastatic resection plus radiotherapy. Okay. So stage 1 FIGO, low risk, single agent chemo. Stage 1 FIGO, high risk, combination chemo plus hysterectomy, family is completed. Stage 2 or 3 with low risk WHO, you are going to go for single agent chemo plus hysterectomy, family completed. Stage 2 or 3 FIGO with high risk WHO, it is combination chemo plus hysterectomy irrespective. Stage 4, it is combination chemo plus hysterectomy plus metastatic resection plus radiotherapy. Okay, so going back. So this was stage 3 high risk. So what should be your management, guys? So this is stage 3 high risk, not low risk. This is stage 3 high risk. So what should be your management as it is stage 3 high risk? So are you going to give single agent or multi-apple agent? So as it is high risk, you are going to go for chemotherapy is the most important, then hysterectomy, guys. So remember, molar choriocarcinoma will melt like snow with chemotherapy. So most important is chemotherapy. So as it is stage 3 high risk, our best answer will go for commence treatment with multi-agent combination chemotherapy. No, hysterectomy is not something which is mandatory now here. What is most important is giving her chemotherapy. More than hysterectomy, or what is more important is giving her chemotherapy. So multi-agent chemotherapy. So single agent is intramuscular methotrexate, 1 milligram per kg body weight. You will give it on day 2, day 5, day 7. You'll give it on day 1, day 3, day 5 and day 7. Whereas alternating with this, you will give folinic acid. And when I tell multi-agent chemotherapy for choriocarcinoma, it is Bagshaw regimen. Does anybody know what is the regimen name of multi-agent? So it is Bagshaw regimen. Excellent, Kaustubh. So it is. So Imaco is. So etoposide, methotrexate, actinomycin, cyclophosphamide. Oncovin is nothing but vincristine and vincristine. So etoposide, methotrexate, actinomycin, cyclophosphamide and vincristine. Okay. So that is regarding the how do we manage. Now, Nasira, even if I would have changed the or removed the lungs, doesn't matter at all because lungs is 0 score. So it is based on the scoring we are deciding what is the management. So we repeat, if you have stage 1 low risk, that is WHO scoring is less than 6 or equal to 6, then it is single agent chemotherapy. If it is stage 1 high risk, what is the management, guys? If it is stage 1 high risk, then it is Imaco. Stage 2 or 3 low risk, it is again single agent chemo. Stage 2 or 3 high risk, you're going to go for echo again. Plus or minus hysterectomy. This is plus hysterectomy, plus hysterectomy. Stage 4 also echo plus hysterectomy plus intrathecal radiotherapy and all those. Okay. So remember this table and this table. These two are important. Okay. And choriocarcinoma is most common after a molar pregnancy. But when a choriocarcinoma comes after a term pregnancy, it is again high risk. So these two tables are very, very important, and I want you to remember those two tables. Next question I have kept on partogram, guys. So partogram is a graphical representation of all the events of labor in a single sheet of paper. So partogram is a graphical representation of all the events of labor in a single sheet of paper. The first half of this paper is mainly speaking about the fetus. So after the name of the patient, age, gravida, time of admission, when was the ruptured membranes, number of hours the membranes are ruptured. So cost of the single agent chemotherapy will be 1 milligram per kg body weight of methotrexate. Yes, Robin, echo is indicated in all high risk WHO scorings. Okay. Right, now we'll start with the partogram, guys. So first you have to check for the fetal heart rate. Okay. So here if you observe, fetal heart rate was around 140, and then it has dropped down to around 80. So fetal heart rate of 80 beats per minute. Is that fine for all of you? Fetal heart rate of 80 beats per minute. Is that fine? So first we are checking the fetal heart rate. So fetal heart rate is now 80. Followed by you have the amniotic fluid and moulding. So I didn't write anything for the moulding, but in amniotic fluid there are three things. If I write C in amniotic fluid, it means it is a clear liquor. If I write I in the amniotic fluid, it means membranes are intact. And if I write M in the amniotic fluid, it means that we are dealing with meconium. So if I write C, it is clear. If I write I, it is intact. And if I write M, it is meconium. So if you have meconium, so it is written M. So this baby is having fetal heart rate of 80 beats per minute with meconium, which is already telling us that we are not dealing with a normal baby. There's something wrong in this baby. Yeah, already हमें पता, पता चल गया यहाँ पे. So the third box is regarding the moulding, guys. So moulding means overlapping of skull bones. Moulding is overlapping of skull bones, right? So we have 3 degrees of moulding, 1 plus, 2 plus and 3 plus. So 1 plus is when parietal bones are just touching each other. So parietal bones approximation is 1 plus. 2 plus is reducible overlapping of parietal bones. 3 plus is irreducible overlapping of parietal bones. 3 plus is irreducible overlapping of . So 1 plus is approximation of parietal bones. 2 plus is reducible overlapping, 3 plus is irreducible. Now when you have 3 plus, it again suggests that there is some cephalopelvic disproportion, but here I didn't mention anything in the moulding. So let us leave that point. And fetal heart rate is considered to be normal if it is between 110 to 160 beats per minute. But as here it is 80, it is not normal. Okay. Next, what you are seeing here is called as cervicograph. So the next column after this we have is the cervicograph. So in the cervicograph, we are now using the modified WHO partogram. So in modified WHO partogram, dilatation starts at, from how many centimeters you are going to start the plotting in modified WHO partogram? So in modified WHO partogram, the plotting starts from 4 centimeters and we consider from 4 centimeters as active phase. But according to the new guidelines, from 6 centimeters is active phase, but we are going to follow here WHO partogram guidelines. So as plotting is starting from 4 centimeters, so from 4 centimeters you are considering it as active phase, and according to WHO, active phase should run at a rate of 1 centimeter per hour. It should run at a rate of 1 centimeter per hour. So with that minimum, we have the alert line. So alert line starts at 0 hours. So it is almost 6 centimeters. So 6 hours it should take. It ends at the end of 6 hours. 4 hours from the alert line, you have the action line. So which ends at 10 hours, right? So normal partogram should be always, if you know this much, more than enough for you to solve, guys. Okay. So normal partogram will be always left of alert line, when fetal heart rate crosses the alert line, you have to refer her to higher center, and when it crosses the action line, you have to do some intervention. Okay, so here, and it also plots the descent. Descent means how is the baby's head coming down. So from 5 to 0 it should come. But here if you observe, the descent has crossed the action line and the descent has been same for past 3 hours. Okay, so normal green is before alert line, left of alert line. Between alert and action line you have the amber zone, and beyond the action line you have the green zone, red zone. So when it is in red zone, you have to do some intervention. When it is in the amber zone, you have to refer her to the higher center, and when the partogram is in the green zone, it is perfectly all right. So here if you observe, there is no dilatation from past 1, 2, 3 hours. 3 hours there is no dilatation, and from past 3 hours there is no descent, right? Okay, and each small box is 30 minutes here. Each small box is 30 minutes. See, it is same, the color is same like your traffic signals, guys. The coloring is same as your traffic signals. Green means go, no? So normal is green color. Amber means refer. Red means do intervention. So before alert line or left of alert line is green zone. Right of alert line is amber zone. Red is do some intervention. Now next to this is the next column to the cervicograph is the contractions, guys. So this contractions, you always see contractions for 10 minutes. So when you are palpating the fundus for 10 minutes, what is adequate contraction? When do you call adequate contraction? So when you are palpating for 10 minutes, in 10 minutes, how many contractions are seen? Those many boxes have to be colored. And if you are getting contractions lasting for less than 20 seconds, then you just put dots. If the contractions are more from 20 to 45 seconds, you're going to draw like this. And if the contractions are for more than 45 seconds, and if the contractions are more than 45 seconds, then you have to refer her to the then it is an adequate contraction. So normally you should have 3 contractions lasting for 40 to 45 seconds. Normally you should have 3 contractions lasting for 40 to 45 seconds. So if you observe in this partogram, you are having 1, 2, 3, 4, and that too severe contractions. So 4 contractions of severe. Next you have, if they're putting any oxytocin, they'll write oxytocin levels. Drugs or IV fluids, whichever are given, are plotted here. Blood pressure is plotted like this, like if it is 140, 150 to 100, so 150 to 100. Pulse rate will be plotted again only as dots. Temperature, proteins, urine protein, acetone, all those are measured. So blood pressure is measured every 2 hours. Temperature is measured every 4 hours. Pulse rate is measured every 30 minutes. And if the blood pressure, if she is hypertensive, then you can measure the blood pressure in every 30 minutes. Now interpret this partogram. So this diagnosis, it is normal. Option A, it is normal. Option B, it is cephalopelvic disproportion. Option C, inadequate contractions. Option C I am giving as inadequate contractions. So option A normal, option B CPD cephalopelvic disproportion, option C inadequate contraction, option D second stage arrest. So what do you think might be the answer here? So there is meconium, there is fetal distress, there is arrest of contraction as well as arrest of descent with adequate contraction. So yes, this is nothing but cephalopelvic disproportion. What do you think should be the mode of delivery in this patient? What do you think should be the mode of delivery in this patient? Will you go for vaginal delivery or cesarean section in this patient? So you have to go for LSCS in the previous patient. Now this session I have exclusively come to tell you some difficult topics, or because you might be reading already so many things. So I wanted to convey this half an hour, something which you would have not read, or which you would have missed, or which you would have been confused. So those are the topics I've picked up to answer in this session. So again, fetal blood sampling, you got a question in the INE CET. So this is something, better to know it than not knowing it. So just be with me to understand the fetal blood sampling also. Okay. So always we first do CTG. If CTG is abnormal, then we go for fetal blood sampling, guys. Okay. So a 34-year-old primiparous woman is induced at 40 weeks of gestation and 12 days for post dates. The fetus is being continuously monitored via CTG. At 6 centimeters dilatation, the CTG becomes pathological and fetal blood samples are taken. The results of fetal blood samples are as sample 1 pH is 7.17 and sample 2 pH is 7.20. What are the most appropriate interpretation and action based on the FBS results? So first let us understand what is the fetal blood sampling, and then we will go back to the question. So whenever you are in doubt that baby might be having some abnormality, you can go based on CTG, you can go for scalp electrode sampling. So that you will take the pH from the fetal blood. So you take the fetal blood from the anterior fontanelle, So membrane should be ruptured to do this. Okay. So once you take the fetal blood sample, if lactate level are less than or equal to 4.1, then or pH is more than or equal to 7.25, you consider as normal. Lactate level less than 4.1 or pH more than 7.25, you consider it as normal. Okay. If the lactate level is between 4.2 to 4.8 or the pH is between 7.21 to 7.24, you call it as borderline. If the lactate level is more than 4.9 or the pH is less than or equal to 7.20, you call it as abnormal. So you have three interpretations: normal, borderline and abnormal. So if scalp pH is more than or equal to 7.25, normal; 7.21 to 7.24, borderline; less than 7.20, it is abnormal. Okay. So what you are going to do here is you are going to take the fetal blood sampling, put the patient in the left lateral. So if it is normal pH is more than 7.25, you have to repeat the fetal blood sampling within 1 hour if the FHR trace remains pathological. So if pH is more than or equal to 7.25, you have to repeat the fetal blood sampling within 1 hour if the FHR trace remains pathological. If it is borderline, so only if your CTG is again pathological, you have to repeat the sample, otherwise no need. Okay? If it is borderline, repeat the fetal blood sampling within 30 minutes if trace remains pathological. Abnormal, if it is less than 7.20, urgent birth, deliver them. So now if your report has come borderline or normal, when you are repeating it afterwards, again if it comes to be normal, FHR trace unchanged and FBS result stable, no need to do third sampling. If it comes to be borderline, so you have to refer her, you have to take the obstetrician's advice. So third FBS might be necessary, or if trace is unchanged, if trace is pathological, then third FBS, right? If trace is unchanged, FBS stable, here you have to take the third sampling. If it is coming abnormal, you have to take urgent birth. So at least remember this part. At least remember the first part. So if I go back to the question, they have already taken two samples. Sample 1 pH was 7.17. Sample 2 is 7.20. So is it normal or is it borderline or is it abnormal? So remember 7.25, 7.20 to 7.25 and less than 7.20. Less than or equal to 7.20. So what should be the answer here? Very good, Nijanta. Excellent. So your answer is absolutely correct. So yes. So here the answer will be 7.17 and 7.20, both are abnormal results. So abnormal result, consider immediate delivery of the baby. Okay, so when only CTG is abnormal, you go for this. Whenever CTG is abnormal, you go for scalp sampling, and this is regarding the scalp sampling. Okay, so next question. A 38-year-old lady came at 36 weeks with breech presentation. What will be the further management? 38-year-old lady came at 36 weeks with breech presentation. What will be the further management? Elective LSCS at 39 weeks, external cephalic version, internal podalic version, assisted vaginal breech delivery. So when somebody comes to you at 36 weeks, you can always try external cephalic version. So external cephalic version, the prerequisites are gestational age should be beyond 36 weeks, liquor should be adequate, membranes intact, singleton pregnancy, so gestational age more than 36 weeks, Liquor should be adequate, membrane should be intact, singleton pregnancy, and pelvis should be adequate, and there should be no contraindications for vaginal delivery. Like if you have placenta previa, don't do the drama of all this turning and all. So there should be no contraindications for vaginal delivery. There should be no contraindications for vaginal delivery. Okay. So this is external cephalic version. Yes, so in primary you can do ECV at around 36 weeks, multi around 37 weeks. So from 36 weeks you can always try ECV. If that fails, then you can either go for cesarean or assisted vaginal breech delivery. There is nothing harm there, right? So that is why here the best answer is ECV. When do you try for IPV, internal podalic version? Internal podalic version is only tried in second twin transverse lie. Second twin transverse lie. So you have two types of ECV, forward roll and backward flip. Now I am going to show you all the images of malpresentation delivery. So try to answer them, guys. First we'll start with this method. So what do you think this method is? And yes, so I have a question here. Can we do ECV for RH negative pregnancy? Yes, you can absolutely do ECV for RH negative pregnancy after giving anti-D. So give her anti-D of 300 micrograms and then do ECV. And then do ECV if mother is RH negative. If mother is RH negative. Okay. So what is this maneuver when you put a finger in the popliteal fossa, flex the knee and pull the leg out? What is this maneuver called as? Very good. So this is the Pinard's maneuver for arrested lower limb. Pinard's maneuver for arrested lower limb. Next, what is this maneuver where you're holding the baby's femoropelvic grip and then you're rotating it 180 degrees on either side as like a car steering? So this is Loset's maneuver. So how do I tell students to remember this is? Remember it as Loset. Losets with extended arm. So with extended arm, love will set in, no? खुले हाथ प्यार बढ़ेगा ना गले लगाओगे तो. So same like that. Love set extended arm. Again, many students confuse Loset's maneuver with Wood's corkscrew. Wood's corkscrew is done for shoulder dystocia. I'm telling how to remember love set. Love will set in with extended arm. Shoulder dystocia mein shoulders are not out. So how will she hug or he will hug somebody? They can't hug, no? So Wood's corkscrew for shoulder dystocia. Right, where you rotate the baby's head with shoulders. This when baby's buttocks are down. Breech is hanging outside. This is Loset's. Okay. So never confuse corkscrew with Loset's. So how are you going to remember the Loset's? You're going to remember the Loset's with love will set in with extended arm. Okay, what is this next maneuver? So these are the maneuvers which you do for the aftercoming head of breech. So these are the maneuvers which you do for the aftercoming head of breech. So what is this maneuver? Thank you, Ikra. So here you are doing suprapubic pressure, malar flexion and shoulder traction. Suprapubic pressure, malar flexion and shoulder traction. So where do you do this maneuver? Yes, so this is called modified Mauritius smelly wheat technique. Modified Mauritius smelly wheat technique. So when you are giving suprapubic pressure, shoulder traction and malar flexion, it is the modified Mauritius smelly wheat technique. So this is called modified Mauritius smelly wheat technique, where you are giving suprapubic pressure, malar flexion and shoulder traction. If you observe the previous image and this image, what is the difference between the previous image and this image, guys? So you can all follow me on my Insta ID also for any further queries, or in my Telegram group also, guys. So this is my ID and this is my Telegram group. So if you observe the difference between the previous image and this image, in the previous image you had shoulder traction, but in this image you are not having any shoulder traction. So when there is only suprapubic pressure and malar flexion without shoulder traction, this is called as Vigor-Martin technique. So this is also done for the after coming head of breech. Another method which we have for after coming head of breech is where you hold the baby at the ankle and pull it up vertically as an arc. This is called as Bern-Marshall technique. This is called as Bern-Marshall technique. So when you hold the baby in the ankle and pull it up vertically as an arc, this is called as Bern-Marshall technique. Next, many students get confused between Bern-Marshall and this image. So Bern-Marshall may you have to wait till the nape of the neck is seen, and this is done in the occipito anterior position. So here occiput is anterior, right? So another method which we have is where occiput will be posterior. So in occipito posterior, you hold the baby at the ankle and pull it up vertically as an arc. This is called as modified Prague maneuver. Okay, and the last one, the best method for delivering the after coming head of breech is by forceps, and the forceps which we use for delivering the after coming head of breech is the Piper's forceps. So here in the Piper's forceps you have a long perineal curve, a lock is present, right? And you have the blades, basically long shank and perineal curve. That is important. So Piper's forceps. So that finishes today's session, guys. So you have a next session coming up. So I'll be ending here, but so another 1 week and you're going to go for the exam. Before your exam, now I would like to tell you what are the topics which I want you people to concentrate are cervical cancer, left and right of cervical cancer, everything know about the cervical cancer, guys. So that is CIN and cervical cancer, HPV vaccination. Okay, next important topic is preeclampsia. Again, you might get question from the preeclampsia. Basics, that is reproductive physiology, tables like cervical mucus kya hoga, spermatogenesis, what happens. So 1 or 2 questions from basics so always comes. Know the management of infertility. Infertility questions. So infertility, have a look on all OCPs, IUCDs, what are the contraindications. So contraindications of OCPs and IUCDs, please have a look. And very, very important, and almost every alternate exam, the topic which has come is emergency contraception. So have a look on emergency contraception also, guys. Have a look on emergency contraception. So these are some, and I'm somehow feeling adnexal mass. That is, you have an ovarian cyst of 5 centimeters, 5 to 7 centimeters. So ovarian mass, endometrial irregular bleeding, how do you manage? So certain those type of questions can come again because they've been repeating a lot. And molar pregnancy, ectopic, so abortion, MT 2022 Act, 2021 Act. So these are something, please concentrate and revise. Any queries before your exam, please feel free to ask. I am going to help you absolutely. So all the best, guys. All our prayers with you. Read very nicely. Any queries, put forward, I'll help you. Nasira, I'll send you one video on biophysical profile. Don't worry at all. One small clip on biophysical profile, definitely I'll be sending you. Okay. Right, thank you guys. All the best. Keep studying. I'll see you soon. Thank you.